All right, thanks and welcome everybody. As Marie mentioned, this is the first of our CPT code update webinars. There's just, as you can imagine, there's just way too much information to throw this into one. So CDM Focused means that we're going to be focusing on those codes that are typically hard-coded in the charge master. So basically, I'm talking about the 7s, 8s, and 9s. Although we've already given a presentation on the E&M code changes, you can refer back to that if you would like to. That's on our homepage. And I'm also going to focus on some Category 3 codes that would typically not be soft-coded by an HIM professional. So if you get through the end of this and go, wait a minute, what happened to the 1000 through 6999? Come back tomorrow. We're doing this again, but focusing on those typically soft-coded or surgical section CPT codes. All right, that's me. We're going to start with the disclaimer that everybody starts with, right? This is current as of this time. They make changes all the time, so it could be updated, but right now this is what we've got, okay? All right, so here's our overview of the numbers, and the question that I always get is, wait a minute, why don't your numbers match what the AMA is telling me? Well, there's a really good reason for that, because when the AMA gives out their numbers for changes, what they're talking about is changes between the books. So when you look at the 2022 book and the 2023 book, those are the numbers they're giving you, and that would include any of the COVID changes that came in during the year. It would include all of the July changes, any last minute revisions. I'm focusing on what's new for 2023. We are going to have separate webinars for July updates and one-off things for COVID. We release those throughout the year. So when I say changes, I only mean 2023, January 2023 changes. And I don't count as a revision if it was a change to the short or medium description only. I'm not going to count that as a revision. Just makes it easier and less confusing. So here's the numbers. Obviously, we had a lot of changes to the E&M section. As mentioned, we have a whole separate webinar on that too, actually, if you would like to get more information on those. We have a decent number of changes to the surgery, and this is where we're going to focus today, is down here. Excuse me. I think everybody's been sick, huh? All right, so let's start with the radiology section. And it actually had a relatively few amount of changes this year, so that's kind of good news. So let's talk about a code that was added. We've got this nerve ultrasound code that has been added. It was basically established to report an ultrasound of the nerve and any accompanying structures in a single extremity. You'll notice that it is comprehensive and that it includes the imaging and image documentation, okay? So in order to report this, you have to do an evaluation of the entire course of a particular nerve throughout the extremity. You're not going to report it with 76882, and I'm sorry, throughout this presentation, I wanted to be posting multiple slides at once because I'm referencing back, but we'll look at what that one is next. And it's important to note that the comprehensive evaluation is going to require acquisition and permanent record of the cine clips and static images to demonstrate the anatomy. So that's just stuff you should have on hand when reporting this. Here's 76882 that we just referenced in the previous slide that can't be reported with 76883. So this isn't a new code. They've kind of modified the description a little bit to hopefully focus everybody in that this is a focal evaluation versus 76883, which is a comprehensive evaluation. Okay, so this would be a limited evaluation of a joint or structure in the extremity other than a joint. It's not going to include all of the elements of 76881, which is ultrasound of a complete joint. So if you're looking at one particular thing, or maybe one or two particular things, like maybe you're evaluating a cyst, maybe you're looking at structures in the extremity, like a joint space or a nerve around a particular joint, not the whole thing. But if that's what you're evaluating, you want 76882. And this one is also going to require permanent records of imaging. I mean, that's pretty much true of any ultrasound code in the CPT book, but just a reminder to you there. We also have a couple of other revisions. I swear these descriptions are becoming paragraphs and soon on to books, but basically what I tried to do for you here is, this is our old description, this is our new description. Anything that is crossed off over here is something that was taken out. This is stuff that was added. So you can see with these two codes, they've added the words or acquisition. So there's not really any changes to these codes. Basically, what they're trying to do is clarify that an acquisition is a separately obtained image with a different radiopharmaceutical. So it can be done on the same day and the same anatomic site. It would be a different acquisition. So if you used a different radiopharmaceutical to go over the same site, that is an acquisition. So they're trying to help you and clarify what exactly you're looking at. So no actual change to this, to the previous two. These changed a little bit more. We again added the or separate acquisitions, and they added some parenthetical notes to help you out there. So if you were looking at lung ventilation and lung perfusion, those would be two separate acquisitions and would typically require a different radiopharmaceutical. Sorry, let me move something out of my way there. I'm having trouble reading my notes. Okay, so if you do a CT scan concurrently, and these notes have been added into the book, you can separately report a concurrently acquired CT scan, and the codes have been put in there into the code book. So another little reminder there on some of these. Now, this one is going to include your CT scan, but the other ones, you can actually separately report a CT scan. So not a ton of change there, but enough. And that is it for radiology. Like that's the least amount I can think of for quite a while. Let's move into the laboratory and pathology. And this too is fairly light for what it has been. All right, so we're going to start with, they added a lot of language to this section, the genomic sequencing procedures. I'm not a pathologist, but I'm going to do my best here. So the genomic sequencing procedures are typically going to refer to, well, they are referring to sequencing of different genomes. So it can be the genome, it can be the exome. So the genome would basically be a bigger whole sample. The exomes are the genome's protein coding regions. But either way, we're looking at this section of code. So typically, these codes are going to use next generation sequencing, which sometimes you'll see referred to as NGS, or massively parallel sequencing, which is always referred to as MPS. I had to look up what this abbreviation was. All of these can target specific combinations of genes or genetic material, or they can just look at the exome or the genome. They are designed to evaluate the genetic material basically in totality. So they're not in general just looking at one particular thing. Whatever they're looking at, they're trying to get at the whole thing. These codes are to be used, this is an important one, this bullet down here. These codes are to be used when the components of the descriptor are performed regardless of technique. So you're not necessarily worrying about whether it's NGS or MPS, but did they perform the components of the code? And when a genome sequencing procedure assay includes genes listed in more than one code descriptor, you're going to look for the code for the primary disorder. So you can be looking at the same genes, for example, for evaluation of breast cancer and ovarian cancer. You want to pick the one that actually goes with the cancer type that you're looking at if there's more than one. Okay. And if you're not performing all the components of the descriptor, you want to go to the tier 1 and tier 2 codes or the unlisted 81479. So basically, you're looking back at that section at 81105 to 81408 if all of the components aren't actually performed. All right, so with that in mind, what they've kind of added and put in to kind of help clarify these sections, here's some of the new codes they added to this. And again, we have whole books here. But we have codes to report separate RNA analysis. So all of this fun here, basically it's kind of sort of the same code. You'll notice the key difference comes down here, that this is RNA analysis. And well, this one's RNA analysis too. Let me get to the next page here. These are all RNA analysis that they've added. So the revisions are going to come in with the DNA analysis. So basically currently, prior to 2023, we didn't have separate codes for the RNA analysis. The codes basically said DNA and RNA, and that was causing some confusion. So they've kind of updated these codes a little bit. They used to say DNA analysis and RNA when performed. They now say DNA analysis or combined DNA and RNA. So what that means is if you're only doing the RNA, you're going to go back to the new codes. Basically just allowing for that differentiation. So if it's DNA and RNA, these are your codes. If it's RNA only, you want those new codes. And I'm not even going to try and read these all off. It's a lot of information there. So here's kind of what we were just talking about. If we are testing for somatic alterations in neoplasm, so basically that's any test that measures changes in the DNA, RNA, or the chromosomes found in tumor tissue. And it's generally done to make cancer management decisions. So if we're doing any of that testing, you're going to report that differently based on what your methods and your analyses are. So if you're doing a targeted genomic sequence DNA analysis or DNA with RNA, kind of what I just said, you're going to use those existing codes that have been modified. If you're doing RNA analysis using a separate method or RNA analysis only on its own, you're going to go to those new codes. So these can be reported together if you use separate methodology. So you could do the DNA and the RNA and not report it twice, actually, if it's using the separate methodology. And like I said, all of that's been added into the coding notes in the book. So that's actually the biggest section of changes in the lab. We do have a couple of other additions here. So we added 84433, which is used to detect TMPT deficiency. People that have this deficiency and get treated with the TPMT class of drugs, which includes azathioprine. I'm not even going to try that one either. Azathioprine is definitely the most common one, But if you have this deficiency and you're given these drugs, it can actually cause bone marrow damage. And you can usually recover from that, but bad things can happen in the meantime if your bone marrow has been damaged. So this would be to test for that deficiency if it's suspected. We also have several codes that have been added to the microbiology section. And basically all of these are to differentiate tick-borne diseases. So other than that top one up there, which is a little bit separate for the hepatitis B surface antigen quantitative, typically that is done to monitor drug therapy for people that are on drug therapy. Qualitative analysis, you're still going to go back to 87340. The next 4 codes down there are all to separate out tick-borne illnesses. So instead of using a non-specific code, we now have one to look for the anaplasmosis, the babesiosis, the tick-borne relapsing fever is the 3rd one down there, and the human monocytic ehrlichiosis is the 4th one. So just helps to differentiate and track between the different tick-borne illnesses, which apparently are on the rise in the US. I wasn't aware of that, but that's part of the rationale for why they have added all those. So that's our regular laboratory section. PLA codes, this actually also was much lighter than what it has been. So what I've tried to do here, we're going to, a quick reminder that the PLA codes are added every quarter, and the AMA doesn't do a lot of validation on the PLA codes. They're not checking to see whether there's an existing code. They're not checking to see whether this is going to be a covered test, any of that. They get a request from this specific lab to add a code, and basically they add it. So it's a very quick process. There's changes to these codes on a more frequent basis, I would say, than the regular lab section. And these are all for a specific manufacturer and test. So just because maybe the main description kind of looks like what you're doing, it is specific to a manufacturer and a test. So I tried to put that all in here for you so that you would have it. So 0355U is for this particular test. This is the name of it from the manufacturer, and Quest Diagnostics is actually the manufacturer that does that. So that's used to assist in evaluation of a potential kidney transplant donor. 0356U is the NAVDX test from Naveris, and that is a circulating DNA blood test. So they actually just take a little bit of your blood, and it can help detect HPV. So basically cervical cancer, and there are a couple others that go in there. 0357U is using some artificial intelligence. It's kind of amazing what they're continuing to be able to do, but this field is just opening more and more. So that is the DAWN-IO melanoma test from Interven Biosciences, and it measures glycoproteins using AI technology, basically to determine what's the best therapy for cancer patients. Pretty amazing. 0358U is the Lumipulse G beta amyloid ratio test. Not going to try the name of that lab either, maybe Fujiribo, I have no idea. But that measures beta amyloid. It's an early detection for amyloid plaques that are part of Alzheimer's disease. So basically early detection. 0359U is the ISO PSA. That's from Cleveland Diagnostics. And that is typically used by patients with a higher PSA that are deciding whether or not to go for biopsy. Just provides a little more specificity in the risk of prostate cancer in those patients. 0360U, you can see is for lung cancer patients. That's a Notify CDT test from Biodesics. And that is it's for patients with lung nodules to help assess the risk of lung cancer. So kind of nice that especially these vulnerable patient populations, before you actually have to get invasive, you have some lab tests that can help you decide whether or not you should be getting invasive. 0361U is the neurofilament light chain from Mayo. And it's basically used if you have a patient with cognitive disorders. It helps predict the risk of actual neurodegenerative conditions. And 036TU is the thyroid guide PX from Protean Biodiagnostics. That's just a sequencing of a bunch of genes, excuse me, to determine the subtype of papillary thyroid cancer. So again, just help to determine what treatment would be best for those patients. Now, I think this is our last one. 0363U is the, I'm not sure how to pronounce that either, CX bladder triage from Pacific Edge. And that takes, you can see 5 different things, and they have a proprietary algorithm that helps determine the risk of bladder cancer, just using urine. So kind of nice. Interesting stuff. And that's it for the laboratory. It's a very, very light year in both radiology and lab, which in previous years have just been slammed with different changes. All right, so let's look at the medicine section here. This one's an easy one. We have a new code that the AMA is kind of preemptively adding. This pre-F RSV pre-F vaccine has not yet been approved by the FDA. It did just get approved for priority review by the FDA, so we are expecting approval or not within the next few months. But this would actually be the first treatment against RSV for patients older, 60 years and older. So we will, of course, let you know if and when that gets approved. All right, we had a code that was added to the ophthalmology services, and this is basically just to differentiate. We had one code that just said orthoptic training. They've now revised the existing code and added a code just to differentiate whether the service is actually done by a physician or just under supervision of a physician by a technician. So that's the treatment of defective visual habits. So it would be defects in your binocular vision. It could be muscle imbalance. It could be, those are typically the ones, but it's basically re-education of visual habits through training. So there's the added code. Here's what they did to the existing code, just added that one's for use by when it's done by a physician or other QHP. And then we just have a couple other minor changes. They changed the word automated to autonomous just to be a little bit more accurate, because the machine actually does the analysis. So it's not really automated, it's done by the machine, so they just changed that word. Frankly, I don't know why they felt the need to add diagnostic dark adaptation exam, but they did, so there you go. No real change to that, just clarifying things. And that is, excuse me, it for the ophthalmology, although this one kind of, sort of. So they've also added a new code for quantitative pupillometry. And this is used quite frequently for evaluation of the traumatic brain injury. So, you know, that's when the physician shines his little light to see how your pupils react. Well, that is great and gives the physicians a lot of information, but it was also a very subjective measurement. This provides an objective measurement because it can more continuously and objectively measure the data, the pupil size, the reactivity. It's a little portable device that is used. So new code for that one. And that's it for nerve conduction. Now we're into the behavior management. So we have several new codes for multiple family group behavior management. It's going to be reported as first 60 minutes, and then there's a code for each additional 15 minutes. So as it says, multiple family and its groups, it would be face-to-face time, and it would be training given to parents, guardians, or caregivers, because you'll notice in this, again, paragraph that this is without the patient present. So this would be basically helping to train families in a group setting how to help correct unwanted behaviors and replace them with more positive behaviors. Some notes have been added to this as well, just so when you're looking at it that you wouldn't report counseling risk factor reduction and behavior change intervention codes with these. And you could report medical nutrition therapy if that was done at the same time as this in the group setting. I don't know how often that would happen, but there's a note in there that you can report that separately. And another quick little note is, because this is initial 60 minutes, you wouldn't report these if you provided 30 minutes or less of training. In a group setting, I would think it'd be hard to do 30 minutes or less and make it meaningful at all. And I guess that's their thought as well. Okay, now we're into more of the fun. This cardiovascular section with the cardiac catheterization, half the hospitals I know have this stuff hard-coded in the charge master, and half have HIM professionals actually assigning it. So I've actually got this one in both my presentations just in case. But here are the new codes that were added. Again, I wish I could display multiple slides at once, because we're going to talk about these in more detail, but here's the code. So we have a selective pulmonary arterial angiography, unilateral. So on one side, same code, bilateral. Then we have a selective pulmonary venous angiography. So that's the difference there. And that one's not split into unilateral or bilateral. And then we have another injection code for selective angiography of MAPCAs, the major aortopulmonary collateral arteries. So that's a lot to look at and take in. Let's actually look at some of the guidelines that have come with these and rationale for doing this. So basically, we added those first three codes there because they wanted to differentiate between angiography involving the pulmonary arteries and the pulmonary veins during cardiac catheterization. So those are those three codes. The next code that was for the MAPCAs, and again, we're going to keep going, and I'm going to give you some pictures and examples of those. Okay. All of these codes, though, include the introduction, the positioning of the catheter, the injection of the medication, and all of your radiological supervision and interpretation. Those are all there. There are notes to guide you that a distinct vessel must be selectively cannulated in order to report each instance of the venous pulmonary angiography or the MAPCA angiography. And here we go. Let's look at a couple. I wanted to give you a picture of what actually the MAPCAs are. So I'm just going to read here from, they are congenital vessels that typically arise from the aorta or the first order branches. So you notice they don't necessarily have to come directly off of the aorta. They could come off of a first order vessel from the aorta. They are distally connected to the pulmonary arterial vasculature, and thereby they provide pulmonary blood flow. Okay, so if you have to selectively catheterize one of these congenital vessels that aren't in most patients, you actually have a code now for doing that. Remember, it has to be selectively catheterized. Okay. And I just wanted to give you a little bit here because there were changes to these pulmonary arteries and veins. So I just kind of wanted to give you a visual on that too. All right, we had one revision as a result of those new codes being added in here now. They had to revise the existing code to clarify that this would be non-selective arterial angiography. There is no non-selective venous, and again, I'm not an interventionalist, so I have to assume that that means that you wouldn't typically do non-selective venous pulmonary angiography. But again, these are keys, right? We added non-selective, we added arterial. Excuse me. All right, they also added a lot of definitions and guidelines to this whole section. So all of this is in your book, but I wanted to call out some of the key things that they're adding on. And none of this is really new. I think there just must have been some confusion amongst coders and other professionals. So they are clarifying on the coronary therapeutics that this whole code system is built on hierarchies. The more intensive services are basically in the lower codes, and it builds as it goes up. So these are our coronary therapeutics. It starts with the angioplasty, it goes to stent, it goes to arthrectomy, and they build on each other. So each code in this range is going to include your angioplasty. They had a lot, or they were seeing a lot of folks with what they suspected of coding angioplasty separate when it was done with stent placement in the same vessel. So they're trying to circumvent that procedure. All right, they also specified that all of these codes include accessing, catheterizing the vessel, crossing whatever lesion you're treating, the radiological supervision and interpretation that's related to the procedure. It also includes closing the arteriotomy that you made and any imaging that you do to verify the outcome of the procedure. That's all included in all of these base level codes. So don't code those separate. You're going to hear me say this multiple times, I think, because they put this in multiple sections of the book. So this must have been a real problem. Diagnostic coronary angiography may only be reported separately if there's no prior study available and you need a full diagnostic study prior to performing any procedure. So patient comes in with chest pain, we're going to get them in there, we're going to do a full diagnostic angiography to find out what exactly we need to treat. Once we know that, then let's see, we find a lesion and you actually treat it. In that case, you can code both a diagnostic study and the treatment. This isn't new again, it's just being really, really spelled out. So that's situation A, in which you could code a separate study in addition to the treatment. You could also code a separate study if you have a prior study, but there's documentation that that prior study is inadequate, or you know there's been a clinical change or suspect there's a clinical change in the patient since the prior study. So if B is the case, make sure that there's really good documentation in there as to why you're doing a second diagnostic study. Okay? And the third reason for doing a diagnostic study and actually separately reporting it would be a clinical change during the procedure that would warrant a separate study. Okay? Otherwise, your diagnostic study is going to be included in all of these services. Okay? You can, however, code if coronary lithotripsy is done in addition to whatever angioplasty stent placement, that can be separately coded using that category 3 code of 0715T. And here we go. There's a lot here. They just put a lot in here. They gave a lot of new guidance on which codes to use for congenital versus non-congenital heart disease. So specifics are that if a patient has anomalous coronary arteries that arise from the aorta or other coronary arteries, or say a patent foramen ovale or a bicuspid aortic valve, those are not congenital cardiac anomalies, and that would be, you would use the regular cardiac cath codes. Okay, unless any of those conditions exist in the face of other congenital anomalies, congenital heart defects. All right, left ventriculography is included in left heart cath for non-congenital heart disease. It is separately reported when performed for congenital heart defects. So, hey, that's a little bit confusing, but that is the way that works. Supravalvular aortography may be separately reported using 93567. And pulmonary angiography and selective venous angiography are separately reported using the appropriate codes that we already talked about. Code 93463 is to be reported when drugs are given for the specific purpose of evaluating hemodynamic response through repeated hemodynamic measurements. You're not supposed to report that just for giving drugs during an intervention or just because you're assessing coronary pressure, flow, or resistance. So you're not going to add that one for shooting dye during your imaging procedures. Okay? It has to be for hemodynamic evaluation. All right, so that is kind of sort of it for cardiovascular. It's complicated coding, so I'm glad that they actually added some more guidelines and helping us out there a bit. All right, they also added a lot of definitions and guidelines to the remote therapeutic monitoring. They got a lot of questions about this. So remote therapeutic monitoring treatment management services, that's when a physician or a qualified health professional uses the results of remote therapeutic monitoring to manage a patient under a specific treatment plan. Okay? It's got to be ordered by a physician or an appropriate qualified health professional, and it shouldn't be used for other monitoring services that are specific, like glucose monitoring, remote monitoring of blood pressure, that kind of stuff. Those have other codes. Excuse me. The data can be objective device-generated data from a device that's worn by the patient, or it can be subjective data from the patient. If you're having the patient write down their blood glucose, that kind of stuff, it doesn't have to be a device. But if it is a device, it has to be an FDA-approved device, a device defined by the FDA as a medical device. Okay. And let's see, does it say this in here? It is for the episode of care, and that always throws people, right? What's the episode of care? So they actually defined it, the beginning of the monitoring through the attainment of the targeted treatment goal. So it could be quite long, it could be short. We also have a new code to report remote therapeutic monitoring, and there it is. You can see we have lots of parentheses there. Therapy adherence, therapy response, daily recording, programmed alert, and it is for 30 days. So it should not be reported unless there are at least 16 days of monitoring. All right, we also, the AMA modified their descriptions for their existing remote therapeutic monitoring. And this was just, they basically took out the specific systems, which was causing confusion, because this one's for respiratory, this one's for musculoskeletal. I guess they just thought that was causing a little bit too much confusion. So basically they took those examples out of there and made it more generic to say therapy adherence and therapy response. Okay, and that is it for the medicine section. We're going to go into the category 3 codes. These are not used. It's by definition new and emerging technology, things that aren't done widespread right now. So I'm not going to spend an absolute ton of time on all of this. I tried to define for you as best I could what it exactly was where I could do that. So if you're, considering doing any of these, remember that just because they have a Category 3 code doesn't mean that Medicare is going to cover it, or anybody else for that matter. But it does mean that it's on track to potentially in the future be promoted up to a Category 1 code. So we have 0738T, which would be treatment planning for ablation of prostate tissue using magnetic field induction. Stuff just, it amazes me. So they can inject magnetic fluid into the prostate and then do different thermal therapies, usually 60 minutes apiece weekly, to ablate the prostate tissue in a much less invasive way. So this would be for the treatment planning. There's 0739, which is for the actual procedure, but generally that's going to be soft-coded. We also have a new code for absolute quantitation of myocardial blood flow. You'll notice that that is SPECT, and it is with some sort of stress, either exercise or medication induced, and that's an add-on code. Okay. If done using PET imaging, you're going to go back into the Category 1 codes and look at 78434. We have a couple of codes for remote autonomous algorithm-based recommendation system for insulin dose. So this is real-time insulin monitoring. So this is via a device. It calculates and can tell you throughout the day what your insulin dosage should be versus, once a day or twice a day or whatever when you do the finger stick. It's just more real time. And that technology right now is through Hygea's, I'm not sure I'm saying that right, DNAV technology. We are starting to go crazy with the bone strength codes. So they've added yet another new one. Basically, the difference between this and the existing ones that are sitting out there is that this one includes vertebral fracture assessment. That's what differentiates it from the other Category 3 codes. And just another quick little note that this is done using an existing CT scan. So it's, again, AI, you scan in your existing CT. There's proprietary software that analyzes all this. If you're actually obtaining the CT scan at the same time, there is a separate code to be added for that. But if you're just sending this in based on a CT that's already been done, then that's included. All right, we have some more bone strength and fracture risk stuff. This is it's from a company called Sectra. There's one screen and there's DXR online. So it takes and it estimates the bone mineral density in the 3 middle metacarpal bones. It's AI, again, it's a fully automated analysis. It requires an X-ray of the hand. So they have 2 codes for that, basically. If it's an existing X-ray that you're just sending for the review, that would be 749T. And if you're actually taking the X-ray of the hand, it's 750T. You don't separately report the X-ray of the hand, you just pick this code. All right, then we have a lot of new codes for digitization of microscope slides, and there's one for each level of pathology, so that's why we've got so many. So this would be when slides are taken, they're scanned, and it's for digital examination. So it's distinct from the direct visualization through the microscope. This is actually digitizing the slides. And this is pretty key right here. This is also in the book. You can't use this solely for educational purposes or solely for the purpose of developing a database for yourself, right? There has to be a clinical indication for this. So again, you'll see in the book, these are all add-on codes you'll notice. So 751T is in addition to 88302. 752T is in addition to 88304. Moving down, 88305 is the middle one, 307 and 309. And again, that's all in the book for which code you would use depending on which level of pathology you've got. We also have some for the special stains. So that top one's going to go with 88312, 88313, 88314, 88319. And last but not least, 88342. These are the immunohistochemistry. 88341 is going to be used with that 761. 88344 would be used with 762, and 88360 is the add-on. 763 is the add-on for that one. Right, I think we finished that. That was a lot of them. All right, we have another add-on code there that can be reported with 93,000 or 93010 for each electrocardiogram tracing performed. So it's, again, just, it's another proprietary software that just provides another set of data for physicians. And this would be if there is no current electrocardiogram performed, and this would be if the electrocardiogram is performed at the same time, okay? And that's the company that actually provides that at this current time. Feels like they added a lot of category 3s this time. All right, so 07, all of these are for transcutaneous magnetic stimulation, the low frequency electromagnetic pulses. So these are for treatment of injured nerves, usually. There's split into peripheral nerves, and there's a primary and an additional code. So this would be per nerve treated, okay? These describe the magnetic stimulation treating chronic nerve pain. It's, again, pretty amazing. They locate the nerve, they mark the skin, they perform the treatment. Sometimes nerve conduction is used to guide and confirm the location. In that case, you don't want to separately report your nerve conduction study. But if you are doing a separate diagnostic nerve conduction study to determine if you're going to do this treatment, you could separately report that, kind of along the same guidelines as with the cardiac cath studies we were talking about. And then I think finally, don't quote me here, but I think finally, we have a lot of virtual reality codes. So this has the potential to be something that's really cool. I don't think it's all that widely used right now, which is why it's just category 3 codes. But we have a virtual reality technology. These are all going to be, no, I lied. They're not all add-on codes, but the top one is. So that would be if you use virtual reality in skill building like communication, emotional regulation, daily function. There's this add-on code. We also have some other virtual reality. So they're looking at this actually replacing monitored anesthesia and some other local anesthesia in some cases. It can only be used on patients that are 5 years and older, and it does require an independent trained observer. It's reported as first 15 minutes and additional 15 minutes. So it's really interesting stuff for sure. So I tried to put some definitions for you down there that it would be a VR-based state of altered consciousness designed to decrease pain and increase tolerance to the procedure. So it creates a computer-generated immersive environment and has so far been pretty successful at lessening patients' pain. Pretty amazing. Don't use them to report the administration of medications. So if you're actually using moderate sedation, deep sedation, monitored anesthesia, you're still going to go to those other codes. Right, 0776 is for the Pro2 Cool system to reduce cellular damage to the brain following a traumatic brain injury. It's just a little device that goes on the back of the neck and head, basically. 0778 is for surface mechanomyography. It's all the sensors that go onto the surface of a muscle, and it basically quantifies the muscle output. So you get precise measurements about the performance of a muscle. It's called figure 8 with a number 8. Brand new code, of course. 0779 is for the myoelectrical activity, and that goes from the stomach through the colon. So it's basically the entire digestive system. So that differs from some of the other existing codes that are designed to do either the upper or the lower digestive system. And then finally, we have the transcutaneous auricular neurostimulation. So that's actually to assess motility in the GI tract. It's usually used for patients with IBS or GI pain, bloating, distension. Just goes behind the ear, really kind of cool. Right, as far as our deleted codes, we have several here that were deleted, either because they came to the end of their life cycle or it was just determined that they weren't going to be used that much and didn't warrant their own codes. So most of these codes now, if they are being used at your facility, they're just going to go to unlisted codes. So you can see that these two for OCT imaging of the skin are going to go to 96999. We have recording of fetal magnetic cardiac signal that's just going to go to an unlisted cardiovascular. All 4 of those are going to go to an unlisted cardiovascular code if you're in fact doing those. The transvaginal biomechanical mapping is just going to go to an unlisted OB/GYN code. Near-infrared spectroscopy studies of the lower extremity wounds, unlisted, and the patient-activated electrocardiographic rhythm-derived event that is without 24-hour attended monitoring is just going to go to unlisted cardiovascular codes as well. There's an add-on code that's being deleted, and basically they've just kind of, they're going to tuck that into a parent code where it's appropriate. There's no replacement for that one. And then there's remote therapeutic monitoring of an online digital cognitive behavioral therapy program. I could take all day just reading these descriptions. And that's going to go to unlisted code as well. We are on the home stretch, just 2 that got revised. And you can kind of see what they did there. They removed the body and limb kinematic measurement based, and they replaced it with real-time motion capture based neurorehabilitative therapy, just to be a little bit more precise and describe exactly what is being done there. And that was a lot, but I think we are done there. And I didn't leave a ton of time for Q&A. I will see if I can get to a couple of these. Some of these may take some research, and that is why we will be giving you an actual written response that will go out to everybody on these questions, and any that I can't get to. Let's see. It looks like there is a question about some HCPCS codes. We are going to hit those a little bit later. So I'm going to skip by that one. The J codes. We are actually, the HCPCS codes, we don't have a separate webinar at this time. I did, however, post an NDC to HCPCS crosswalk on the main dashboard of VitalWare for those new therapeutically equivalent biosimilars and which NDCs. So if you are a VitalWare client, just go out to the main dashboard and it's right there in our reference documents. In fact, I think it's probably the report that is the latest. If you have trouble finding that, feel free to send a question to your account manager and they would be happy to help you find that. Looks like I've got a lot of questions on HCPCS codes. Yes, we've had several questions. I have somebody asking about HCPCS code C7513 to C7553. Those are new HCPCS codes. They're all assigned a status indicator of E1 by Medicare, which means they would be not covered, statutorily excluded type codes. And they all basically have descriptions that are very, very similar to existing CPT codes. And CMS has not said a word yet about why they have done that. So all I can do is speculate a little bit, but I would say if you are a hospital under the OPPS, you do not want to use those. There's no reason to use those. There are equivalent CPT codes that are actually covered by both Medicare and most major insurances. It's interesting to note that all of those codes are covered in the ASC setting. So if you have an ASC, I can't honestly say right now why they've done it this way, but those are covered codes in the ASC. So we're really hopeful that when CMS publishes the transmittals for the January updates to the OPPS and the ASC, that they provide us some guidance. And we will, of course, make sure here at VitalWare that we get out vital alerts and that we help you with that. But for right now, if you're a hospital, don't try and create something for those. You'll just be making trouble for yourself and have the potential to get claims denied. Okay. Let's see, there is time for maybe one more question. I've got a question for 96202. Is there only one caregiver and parent present, and that is all the patient has? Can this code still be used? So I think, let me make sure I'm looking at the right code there, 96202. The book is not quite as easy as it used to be. That is the code for the multiple family group behavior management modification training for parents, guardians. And that does have to be, it is for groups and multiple families. So if we only had one caregiver present, that's not going to work for those codes. It does have to be multiple family group setting. And I think that's probably the time I have. I will make sure I've got everybody's questions, and we will make sure to get all of those answered via a written Q&A, and that gives me a little bit more time actually to do some research and get you a better answer than just off the cuff too.
Awesome. Thanks, Jen. That was great. Before our final closing remarks, I'm just going to launch a poll really quickly asking if you would like to be contacted by us to schedule time to learn more about our products and services. So while I'm wrapping up, if you want to take a minute to answer that, we'd appreciate it. We hope you enjoyed our session and found it very informative. I'm sure you did. There's a lot of great content there. As we mentioned earlier, we have posted the presentation already, and we'll be sending out the CEU certificates following the webinar by end of day tomorrow. And a reminder that we have 2 more webinars this week, as Jen mentioned, parts 2 and 3 of the CPT Update series, tomorrow the 14th and Thursday the 15th, both at 12 p.m. Central Time. We also have a survey that will pop up at the end of the webinar if you would like to give us some feedback as well on today's session. And I think that's all that we have for today. Thank you so much for joining us, and have a great rest of your day. Thanks, everyone.